Welcome to this explainer. Breathing is something most of us just do without even thinking about it, right? Until, suddenly, we can't. Today, we're diving into a disease that you, or maybe someone you know, likely deals with every single day: asthma, or chronic airway inflammation.
300 million. That staggering number represents exactly how many people worldwide fight an invisible airway battle every single day. I mean, it literally spans all income classes and all age groups. And because of its sheer prevalence, it's one of the leading causes of school and work absenteeism across the globe, not to mention a major driver of emergency room visits. It's really a massive, quiet epidemic.
So here's our game plan for today. 1, we'll go inside the asthmatic lung. 2, look at triggers and allergic sparks. 3, the physics of an attack. 4, assessing the danger level. 5, the treatment arsenal. And finally, 6, emergency rescue interventions.
All right, let's jump straight into part 1, inside the asthmatic lung.
To really understand this crisis, we first have to look at the baseline vulnerability of the patient. There's this stark contrast between a relaxed, healthy airway and an asthmatic one. A normal airway has thin walls, completely relaxed smooth muscles, and a nice wide opening, or lumen, for free airflow. But an asthmatic airway? It suffers from this dangerous triad. First, persistent inflammation creates a swollen edematous lining. There's literally just less space for air to move. Second, you get rapid bronchoconstriction, where the smooth muscle layer rapidly tightens. And third, excessive mucus production from goblet cells clogs whatever narrow space is left. Basically, the airway is chronically inflamed and always primed to react.
Moving on to part 2, triggers and allergic sparks.
So what exactly ignites this highly reactive environment? Well, the crucial point is that a massive variety of everyday elements can spark a severe reaction that chokes off vital airflow. For a lot of people, it's an allergic mechanism. Things like dust mites, animal dander, or mold. These trigger IgE antibodies in the airway, which then activate mast cells to release inflammatory chemicals like histamine and leukotrienes. But here's the thing. Allergens aren't the only sparks. Viral or bacterial infections like pneumonia or RSV, a blast of cold air, a really hard workout, emotional stress or panic attacks, and even common medications like ibuprofen or beta blockers can cause that smooth muscle to rapidly clamp down. Okay, part 3. The physics of an attack. Let's think about how this actually feels and functions physically when a trigger hits the lungs. Trying to breathe through a constricted airway is exactly like blowing through a narrow straw. If you blow through a wide straw, air moves easily in large volumes and it's practically silent. But try blowing through a narrow straw and you get turbulent airflow. It takes way more effort to move lower volumes of air, and that turbulence is exactly what creates the characteristic wheezing sound of an asthma attack. But the danger goes way beyond just the sheer effort of breathing. Because of the narrowed airways, breathing out actually becomes harder than breathing in. Imagine the utter panic of feeling your lungs fill up, but being physically unable to empty them. Patients quite literally stack trapped air in their lungs. It's a dangerous claustrophobic trap called dynamic hyperinflation. Just picture breathing in 20 units of air, but the resistance only lets you exhale 15. You now have 5 units trapped in your lungs. The next breath, you take in another 20, but only exhale 15 again. Now you've got 10 units trapped. With every single breath, you have less and less functional room to breathe. Which brings us to part 4, assessing the danger level. As this trapped air builds, we enter a critical escalation of physical distress. It starts mild, with slightly rapid breathing, known as tachypnea. But as it turns moderate, you start seeing accessory muscle use. The skin around the ribs starts physically sucking in. The patient might be rocking in a chair, struggling to speak, and their oxygen saturations start dropping. When it hits severe, they are markedly distressed and literally cannot even complete a sentence. Finally, life-threatening asthma sets in. This means cyanosis, where lips and fingers turn blue, and an altered mental state because of the severe lack of oxygen. And that brings us to a terrifying medical red flag that every healthcare provider is trained to look for: the silent chest. If an asthmatic patient stops wheezing, you might instinctively think they're getting better. But beware. If they are visibly distressed and you hear no wheezing, zero air is moving. The bronchospasm is so completely tight that the airways are fully shut. This is an absolute life-threatening emergency. Fortunately, we can fight back. Part 5, the treatment arsenal. The management of this disease is split into 2 distinct battlefronts. First, We have the relievers. These are short-acting bronchodilators, like albuterol, and they're used for rapid symptom relief. They essentially force the smooth muscles to relax when an attack hits. But the second, and arguably more critical category, are the controllers. These include inhaled corticosteroids, long-acting bronchodilators, leukotriene antagonists like montelukast, and LAMAs. Patients absolutely rely on short-acting relievers to survive sudden attacks, but preventing long-term airway damage requires these daily controllers. In fact, inhaled corticosteroids are the true cornerstone of long-term asthma management. Just using a rescue inhaler only opens the airway temporarily, kind of like a Band-Aid, but it doesn't fix that swollen edematous lining we talked about earlier. So the most vital takeaway for daily survival is treating the underlying chronic inflammation, not just constantly chasing symptoms. But what happens when the controllers fail? Part 6, Emergency Rescue Interventions. When a patient arrives at the ER in a severe crisis, doctors follow a strict algorithmic thought process. Step 1 is immediate oxygenation and nebulization, delivering a continuous mist of bronchodilators directly into the lungs. If that isn't enough, Step 2 introduces high-dose systemic corticosteroids, either oral prednisone or via IV, to aggressively shut down that active inflammation. Still struggling? Step 3 is IV or intramuscular magnesium sulfate to force smooth muscle relaxation. And if all else fails and the patient enters a silent chest or respiratory failure, Step 4 is intubation and mechanical ventilation. And this is notoriously difficult because of that dynamic hyperinflation and air trapping we discussed earlier. To add a dose of visceral human reality to these clinical protocols, deploying magnesium sulfate into a muscle is an incredibly painful, yet potentially life-saving intervention. It rapidly relaxes smooth muscles, but as the clinical guidelines bluntly state, it burns terribly and it can cause a significant drop in blood pressure. The side effects, flushing, dizziness, intense pain, really just highlight how incredibly aggressive emergency treatments have to be to reverse a closing airway. Reversing an attack also requires intense medical persistence. When a patient isn't responding immediately, the natural instinct might be to panic, but the clinical rule is clear. Do not give up on nebulization. You have to keep aggressively fighting the inflammation. Sometimes patients need 3, 6, or even 9 back-to-back nebulizer treatments before the tide turns. As long as the patient is awake and communicating, you maintain that continuous nebulization until the tight, swollen airway finally begins to yield. To wrap up our explainer today, I want to leave you with this provocative question. Whether you have asthma yourself or care for someone who does, are you merely surviving your symptoms with a rescue inhaler, or are you actually controlling the underlying inflammation? Because you see, surviving the spark is one thing, but actively putting out the fire requires a real long-term commitment. Thanks so much for joining me on this journey through the airways. Keep exploring and keep learning.